Hi, my name is Claudia Lewis. I'm a respiratory therapy student. I'm going to go over some vent initiation with y'all. So you've been called to the ER. You have a patient coming in via EMS. He's a 45-year-old male who fell 30 feet at a construction site and has a probable closed head injury. So he's 5'8". He should weigh around 70 kilograms. So we're going to start there. Where'd he go? There it is. It's going to be loud for just a second while I'm setting it up. Here, they automatically have their circuits all hooked up and they've already done all their checks. It takes 2 respiratory therapists to do the check, and then it's covered with a big plastic bag so that you know it's ready to go. And you don't have to do all that in an emergency because that would be bad. So when you get there, or when he comes to the ER, you find he's on a bag valve mask. He's been intubated in the field at 20 beats a minute, and you suspect a closed head injury. So, what did I say? 70? Yeah, 70. We're going to change that to 70. Nope, too far. 70. Stand by. Yes, I know. Okay. Let's do. Okay, so this guy. What are we going to do? Let's do a volume. We're going to do controlled volume. We're going to do 100% oxygen. Total volume should be 350. 50. Okay, and when I do that, it said the minute ventilation would be around 4. That's kind of nice. Expiratory time. Let's do 1. It makes for easy math. I like 1 a lot. Respiratory rate. Okay, so it's closed head injury. Do we want to go fast or do we want to go slow? Depends on your area and your protocols, and the debate in that area or protocols about decreasing intracranial pressure by hyperventilating. So let's go a little faster. Let's go 20. That gives me a minute ventilation of 7. That's pretty cool. Expiratory time of 2 seconds. That will work. PEEP of 5. Let's turn the PEEP way down. Let's go 0. We're going to avoid some PEEP while we can. Oh, look, I actually had that math on there. So we're going to start that. CMB. Yep. Yeah. Okay. Start. Perfect. All right, cool. So we're not going to do the PEEP and stuff because we really don't want to increase intracranial pressure. So he's already been intubated in the field, so you're going to verify the placement of that. There it goes. So we're going to verify the placement of the tube by listening over the trachea and both lungs and the stomach. If you hear air in the stomach, it's probably in the wrong place. There should not be air in the stomach. Or if you hear only on the right, it needs to be pulled out just a hair. So that's working really good. Alrighty then. So we're assuming this is a closed head injury. Do all the normal stuff you do for every patient. Check their vital signs, their heart rate, their blood pressure. Do an arterial blood gas and see where you are to start with. It may be normal to start with because nothing's had time to go wrong. Send them for a chest x-ray to verify the placement of the tube, do the CT, all that good stuff. Look for swelling in the brain. Verify your cuff pressures. This is my favorite part. So you're checking the pressure of that little cuff right there. You can take your pilot balloon, which I blanked on that word last time. Fantastic. Got right around 22. That will work. If I'm going to let some air out, I can push on the red button. And I can feel my pilot balloon going soft, but I don't really see my cuff getting softer. Cool. Alrighty. So we would document all of our settings and alarms. which I don't think I set the alarm. I forgot, which is okay. It kind of remembers the last alarm setting. So we have high respiratory rate of 35, peak airway pressure 40, minute ventilation 10. He's set at 7, low is 2.9. Apnea, I gotta change it to 15 for the protocols here. Boop. Perfect. ETCO2, high 60, low 30. Okay. And that's for the CO2 sensor that would be in the system, not like an ABG. So let's say that they send him to CT and they realize that he doesn't have any kind of internal brain injury. It's just an outside. So we're going to change some settings. We're going to drop his O2. Boop. Let's drop it to 90. Frequency, we're going to drop that down. Let's go 15. And we're going to watch that. We're going to watch the patient, see how they tolerate that. And every time you do a change, draw an ABG. Every time you do a change, document it in your charting. Okay, that's cool. And you just want to document all the high alarms, all the low alarms, all the settings, what they're actually doing, if they're on a support mode as opposed to a control mode. Let's say he starts to do better. I'm going to change it to SINB. Nothing else changed, which is super helpful. Oh, and I can add some PEEP now because he's been here a little bit, been in the bed. We know his brain's okay. Perfect. Activate SINB mode. Very nice. Okay. That will work very well, and I will, of course, document that in the chart. They do vent checks here, I think, every 4 hours, and do ABGs anytime they do a change, usually within about an hour. And they also do them, I think, at the end of each shift. And they do 12-hour shifts here, so at least twice a day. More often if they actually do changes, like change the settings, and anything like that. So, thank y'all very much.